So today's topic of the video is stroke and transient ischemic attack. It is a very high yield topic, and according to the students who have given AMC in 2026, stroke and DIA is kept repeating itself, and so it's a very important topic in the 2026. So, starting with the video, what is transient ischemic attacks? So, transient ischemic attack is actually the episode of focal neurological dysfunction with an abrupt onset and that lasted less than 24 hours and had a vascular cause. So, if a patient comes to you with focal neurological dysfunction and the symptoms of focal neurological dysfunction, for example, mouth deviation, dysphagia, or transient vision loss, or the leg weakness that stayed for less than 24 hours and it was sudden and it had a vascular cause, so it is termed as the transient ischemic attacks. So another definition is according to the is based on the impact on imaging. If we do the imaging, and we have two definitions, that is the mild stroke. Mild stroke would be the term when if brain infarction is identified on MRI even though symptoms have resolved. So symptoms have completely resolved, but if the patient had already undergone the MRI, he had a brain infarction. So it would be mild stroke. But TIA would be considered if symptoms resolve completely within 24 hours and there is no brain infarction on imaging. So, if the question states that the symptoms have resolved and there is an in fact on imaging and there is an option of mild stroke, so you would mark the option of mild stroke. But if the patient has symptoms of focal neurological dysfunction which resolved completely within 24 hours and there is no brain infarction, that would be transient ischemic attack. So it is written in ETG. You can check there. Risk of stroke after TIA is about 10% at 2 weeks, and half of these mostly occur within the 48 hours. And the factors that increase the risk of subsequent stroke after TIA are the age of more than 60 years, BP is more than 140 by 90, and the patient is of hypertension, symptoms that lasted more than 1 hour, and the patient is has a history of diabetes. So these are the factors that increase the risk of subsequent stroke. So in this video, I am going to be telling you about the management of stroke and hemorrhage. And I have extracted the text from the ATG guidelines, because so you do not have to go through every text that is written there. So, what is the immediate treatment for acute ischemic stroke? So, first of all, whenever the patient comes to you with the focal neurological symptoms, dysfunction, first of all, you have to do the CT. CT is the first line. First step you have to do, because you have to differentiate between the hemorrhagic stroke and ischemic stroke, so that you can approach the patient and you can carry on the treatment according to that, because the treatments of ischemic stroke and hemorrhagic stroke are different. So first of all, you have to make sure that the stroke is ischemic or hemorrhage, and you can do that with the CT scan. And you have to follow the ABC, airway breathing. You have to correct the airway breathing and circulation. So for very first, the drug of choice for ischemic stroke is the IV thrombolysis. IV LT that is recombinant tissue plasminogen activator. And if the patient has come to you and the symptom and the time elapsed from the symptoms onset of the symptoms is within 4.5 hours, so IV is the drug of choice, is the treatment of choice. So if you have to do the IVLT within the 4.5 hours of symptoms onset. But first of all, most of the times the patient has a raised BP with the symptoms of stroke. So first of all, before IVLT you have to correct the BP of the patient and reduce the BP up to 125, 185 by 110 or lower. Then we are going to start the therapy of IVLT. And during the treatment of IVLT, if the patient also gets raised BP, so you have to correct it urgently. Now, BP and neurological status of the patient are monitored for 24 hours after the LT plays, because the main adverse effect is bleeding, including intracranial bleed. So, it is the main adverse effect of LT plays. And also, aspirin should also be withheld for 24 hours to minimize the risk of bleeding after LT plays. Now, endovascular thrombectomy. If the stroke is due to large vessel occlusion, that is internal carotid artery, basilar artery, or middle cerebral artery, which is usually detected by the CT angiography. So, endovascular thrombectomy is the treatment of choice, and it is highly effective within the 6 hours of symptoms onset. So, same person who has been given IV thrombolysis can also be given the treatment of endovascular thrombectomy when the CT angiography is done. However, endovascular thrombectomy is appropriate when LT plays is contraindicated. For example, if the patient has come to you and and the symptoms onset of the symptoms has elapsed more than the time elapsed from symptoms onset is more than 4.5 hours to 6 hours, between the 4.5 hours and 6 hours. So the endovascular thrombectomy is now the treatment of choice, and it is too late for LT plays. So in this case, endovascular thrombectomy is appropriate. Now coming towards the antiplatelet therapy. Antiplatelet therapy, the patient benefits when given aspirin within the 48 hours of acute ischemic stroke, and do not give aspirin until the hemorrhage is ruled out. So, on CT scan, first we have to rule out the hemorrhagic stroke, and then aspirin can be given. And aspirin 300 milligram is given in the first dose. Then we are going to reduce it to 100 milligrams, and it is then advised daily afterwards in the patients of stroke. Now, in general, we have to avoid lowering BP in the first 48 hours. That is the acute phase of ischemic stroke, unless unless the blood pressure is of malignant hypertension, hypertensive encephalopathy, or patient is receiving alteplase. So, in the acute phase, we have to avoid the BP lowering step. Now, there is another treatment choice, that is neurosurgery for acute ischemia. So, if the patient has a cerebral infarct that is too extensive that it can cause the cerebral edema at the level that it can be fatal. So, neurosurgery can be performed, and it is done in the selected patients, that is the aged 18 to 60 years of age. More than 60 years, surgery is not indicated, and the patient is with extensive infarct. So, hemicraniotomy can save life, and neurosurgery is considered within 48 hours, and large neurosurgery is indicated within 48 hours. In the cases of large space occupying cerebellar infarcts, ventricular drainage and posterior fossa decompression are the treatment of choice when there is large space occupying cerebellar infarcts. So there are some general measures we have to take when we are dealing with a stroke patient. Most of the times there's dysphagia. The patient is presenting with dysphagia and swallowing is affected. So we have to give the fluids and drugs very cautiously, and we can consider the option of nasogastric tube. But dysphagia often improves rapidly, so fluids and drugs can be given orally afterwards. We have to be cautious of using the BP lowering drugs, and BP lowering drugs are preferably be given orally if the systolic is more than 220 or diastolic is more than 110. If the patient is hypoxic, we are going to give the supplemental oxygen. If the patient has fever, paracetamol is the drug, and we have to avoid the IV fluids containing glucose because hyperglycemia has worst outcomes. So, any fluid that contains glucose, we have to avoid these fluids while fluid replacement. And if the patient is immobilized by the ischemic stroke, we have to give the low molecular weight heparin to prevent the DVT. Now, there is secondary prevention of the stroke after the stroke has occurred. So, after stroke and TIA, first of all, we have to assess the patient for diabetes. And we have to advise the patient to eat healthy. Alcohol should not be consumed more than 2 drinks daily. Smoking cessation is advised. So certain drugs that we have to keep the patient on, we have to keep the patient on certain drugs after he has experienced a stroke or TIA, and the management of a stroke and TIA are same, is same. So antiplatelet therapy, whether it is acute treatment or secondary management, secondary prevention of stroke and TIA, both cases, in both cases the management is same. So antiplatelet therapy, it contains a low dose 100 milligram of aspirin once daily. If the patient has recurrent cerebral event, aspirin can be combined with dipyridamole, but most common adverse effect is headache. And if the patient cannot tolerate aspirin, clopidogrel can also be given. Oral anticoagulants are advised in the patients with atrial fibrillation. So, in patients with atrial fibrillation, the anticoagulants are direct acting oral anticoagulants. And atrial fibrillation is actually the most common source of cardiogenic emboli. So, stroke is if the stroke is due to the cardiogenic thromboembolic event, and the patient has a history of atrial fibrillation. Due to the atrial fibrillation, we have to keep the patient on oral anticoagulants. And if the cardiogenic emboli is non-atrial fibrillation in nature, non-atrial fibrillation in nature. So we have to administer the warfarin in place of direct acting oral anticoagulants. In cases of the valvular, especially in the case of valvular heart diseases, and the emboli is from that source. So we have to use the warfarin. Now, coming towards the statins are also given in all the cases, and specifically in whom the stroke is presumed to be due to atherosclerosis. There is also a condition called carotid stenosis. If the stroke is due to carotid stenosis, so if the carotid stenosis, important point from this condition is that if the carotid stenosis is more than 70% on imaging, and the patient is symptomatic, that is with mild stroke or TIA, he has experienced mild stroke or TIA, so we have to do urgent carotid endarterectomy. So more than 70% cardiac carotid stenosis in the symptomatic patients, we have to treat him urgently. Now coming towards the intracerebral hemorrhage. We have to rule out what is causing the intracerebral hemorrhage. For example, the coagulation factor. If the intracerebral hemorrhage is due to coagulation factor deficiency, we have to do the factor replacement. If the patient has thrombocytopenia, we have to replace the platelets. If the patient is on warfarin therapy and he has experienced the intracerebral hemorrhage, we have to give the prothrombin complex, concentrate, fresh frozen plasma, and vitamin K. And a very important point in the case of intracerebral hemorrhage is that if the patient has increased blood pressure and the patient has a stroke due to the hemorrhage, we have to lower the BP aggressively up to the 140. Um, so this is a very important point. In ischemic cases, we have to lower the BP, but not aggressively. There is a certain limit up to which we have to lower the BP. That is 180 by 110. But in the case of intracerebral hemorrhage and in ischemic stroke, we do not have to always lower the BP, especially in the acute phase. So in intracerebral hemorrhage, we have to lower the BP aggressively up to the 140, and the treatment is surgical evacuation, and there are no antiplatelets given in intracerebral hemorrhage, and there are no anticoagulants advised in the cases of intracerebral hemorrhage. Now we have the subarachanoid hemorrhage. Subarachanoid hemorrhage is presented with the acute severe headache. The patient complains of the most severe headache in his life, or thunderclap headache, and it is the presentation in 75% of the cases. Others may present only with the loss of consciousness. So we have to do the CT. We have to rule this. We have to rule out this subarachnoid hemorrhage with the CT. But if the CT is normal and the suspicion and there is high clinical suspicion of subarachnoid hemorrhage, we have to confirm it by lumbar puncture or urgent MRI. And a lumbar puncture, there would be blood. Mostly subarachnoid hemorrhages are due to ruptured intracranial aneurysm. So management is to treat aneurysm surgically or endovascularly. There is a very important question in the blue book that the most important reversible single most important reversible risk factor for the ischemic stroke is hypertension. So, hypertension is the single most important reversible factor for ischemic stroke. And in the cases of coronary artery disease, in the cases of coronary artery disease, the most important reversible risk factor is hypercholesterolemia. And in cases of peripheral artery disease, the most important risk factor is smoking. So this is a question in Blue Book, and these are some of the very important points you have to keep in mind. Let me repeat it. Hypertension is the single most important reversible factor for ischemic stroke. And for coronary artery disease, it is hypercholesterolemia, and for peripheral artery disease it is smoking. So I hope you understand the lecture and you understand the management of a stroke. I have given the management straight up and no other useless theory. So if you like my videos, kindly subscribe the channel, share among your colleagues, and like the video. Thank you.